Welcome, everyone. My name is Norm Thurston. I am the Executive Director of the National Association of Health Data Organizations, or NADO, and I'm also on the Executive Committee of the National Academy for State Health Policy. We're especially pleased to welcome you all today to our crossover session. This session is supported by the Foundation for Opioid Response Efforts and also by Friedman Healthcare. On behalf of our sponsors, I want to thank both the NADO and NASHP staff for organizing this historic joint conference session, which has brought rich and timely content to a record number of attendees. The COVID pandemic has reminded the world how much we need smart health policies backed by rigorous health data to save lives. We are lucky to be working in this field, and I am grateful for the enormous contributions of everyone that is attending here today. Again, thank you to our sponsors and especially to Friedman Healthcare, one of NADO's featured partners, for their generous support of this session, with examples from 3 pioneering states as they explore the ways good data drive good policy. Let's learn their lessons so we can apply them in our own work. Thank you. Our first presentation will be by Julia Tomaroli and Vanita Ball from Colorado's Center for Improving Value in Healthcare. Julia?
Hello, everybody. My name is Julia, as Norm just introduced. I'm also joined by Vanita Ball. She's in the room with me. We're socially distanced, but we're just using the same computer, so there's going to be a little shuffling later. But we are pleased to be here to talk to you, or I guess online, to talk to you about the APCD support of the Colorado out-of-network legislation. So go ahead and go to the next slide. So this is generally what we're going to discuss today, just some basic topics about the APCD and how it relates to House Bill 1174, which is the legislation for the out-of-network healthcare services. We'll discuss the implementation facts and touch on the methodology, and then, of course, discuss some of the gaps in delivering the fee schedules that we were tasked with, and also, of course, touch on the lessons learned, which there are many. Next slide. So briefly, the Colorado APCD is the state's most comprehensive source of healthcare insurance claims information. CIVIC, the Center for Improving Value in Healthcare, administrates this wonderful resource. So we maintain and enhance it, and we also use it to conduct analyses and publish results to advance the triple aim. Next slide. So the out-of-network bill, how that relates to us at CIVIC and as the APCD is we were tasked with helping to reprice some claims, especially for, or I guess specific to services that were done by an out-of-network provider in an in-network facility. It also addresses emergency care at out-of-network facilities. One thing to note, that this bill does include ambulance services, ground ambulance services. However, the APCD fortunately was not tasked with addressing that Herculean effort. That is a really complicated process, so we didn't have to deal with that. But the other stuff we were all very involved in. For those policy brains out there, there's a lot of details on this slide about the policy and how it was implemented, but specific to the APCD, this payment standards section down there, that's where we were really involved. We were paying very close attention to that bullet, the 60th percentile, and then below that, the 50th percentile. Those were the two bullets that were most important to us as we were tasked with providing that information for those claims. And in general, this policy provides that for a given procedure, for a given service, in these circumstances where it's an out-of-network provider in an in-network facility or an emergency facility bill, the rate of reimbursement will be the greater of either of these two bullets for the different scenarios. So we can go to the next slide, but that slide is rich in information for all of you to look into. So some implementation facts, as I've mentioned, the APCD was used to produce the fee schedules to reprice these claims in these scenarios. So we produced fees for each of the 9 Division of Insurance rating regions across the state. We'll get into this in a couple slides from now, but there was quite a process of deciding what to happen when the volume of a service was low. We ended up starting with the Division of Insurance rating area if there was enough volume there, but then we would jump to the statewide volume if that was too low. And then if the statewide volume was too low, then it would go to the carrier's median and network rate. So we can go to the next slide. So for those data brains out there, this slide really tells you exactly how we wrote our SQL query to pull this information out of the data warehouse to then create these fee schedules. So we looked at commercial claims, fee for service also, 2018 for the service date, primary payer, in-network provider, and also the place of service being in a facility, especially for those professional services. Next slide. So as I mentioned before, one of the challenges that we had with producing these fee schedules is just making sure that we could produce a stable estimate of these services, and we ended up with a 30 volume threshold. So if that service happened at least 30 times in 2018 in the commercial, all that, get the stuff from the last slide, we wanted to be able to produce a stable estimate. And these graphs down below, you can kind of see it might be a little bit too small, but we were looking at the interquartile range for each of these services as the volume of the services increased. So there's still a couple outliers out there, but generally around 30 is when the interquartile range kind of stabilized a little bit. So we were able to firmly say that a 30 volume threshold worked really well for us. And with that, I'm going to turn it over to Vanita. We're going to take another socially distanced couple seconds to stay away from each other, but go ahead.
Alrighty. Next slide, please. So we developed a fee schedule for anesthesia services separately from other provider services because the reimbursement formula for anesthesia services is different. The payment for anesthesia services is based on many factors: the CPT-4 procedure code plus modifiers that identify the provider of the service, maybe an anesthesiologist or a CNRA, and modifiers that describe whether the level of supervision that the provider received in delivering the anesthesia. The modifiers also describe patient physical status or their anesthesia risk. And then there was a factor of time units, or the amount of time taken to deliver the anesthesia service. Anesthesia claims presented, as all of our claims did, significant problems. They were low volume for each CPT code plus modifier combination, and there were inaccurate and inconsistently defined time units. Unfortunately, we are not getting good quality data from the payers. So what we did was adopt the method that was used by the state of Oregon, which was not to calculate a fee schedule per se, but to calculate a regional conversion factor. And a conversion factor is a dollar amount, which when combined in a formula with values, standardized values for CPT-4 codes and modifiers, and also time unit values, produces a payment amount. So what we were doing was providing a conversion factor that the payers could then use to calculate a payment for the out-of-network service based on the other data that was available to them on the claim that was submitted. This allowed us to use an aggregate of all the available data in the APCD that was clean for anesthesia claims. Next slide, please. So this is a stepwise description of the process that we use to calculate the anesthesia conversion factor. I won't go into it in detail, but we selected the anesthesia CPT-4 code and modifier combinations. Then we eliminated bad data, claims with bad data, and also eliminated outliers, claims where the payment amount per unit of time was either very low or very high. And then we calculated the conversion factor for each CPT-4 and modifier combination, and then aggregated or took the weighted average across all the CPT-4 and modifier combinations for the particular region. Next slide, please.
We have about a minute and a half.
Okay, moving right along. So with emergency services, again, more challenges. Payers were paying emergency services as bundled services, but they didn't define the bundles similarly. Not only that, but the out-of-network legislation defined out-of-network emergency services as services prior to the time at which a patient was medically stable and able to be transferred to an in-network facility. So we had to define, since emergency services can encompass a variety of hospital services before a patient is stabilized, we had to define ultimately case rates for different types of services that an emergency patient might undergo, which included observation services, maybe even an outpatient OR surgical procedure, and finally an admission to the ED. Next slide, please. The admission to the from the ED was particularly problematic because in those cases, a patient might have been stabilized sometime after their admission, and then there might have been a delay before they were transitioned to or transferred to an in-network facility. And with an inpatient claim, all the services are bundled together, and there's no way to really split the services that occurred pre-stabilization. Next slide, please. So in summary, these were the gaps in delivering fee schedules. Again, poor quality data and no standard method of defining services for establishing these fee schedules. Next slide, please. And so with the lessons learned were really engage with the regulators, the payers, and the providers really early to resolve methodological problems. Work with the payers to try and fix problems with data, the data quality that is, and work toward changes in the legislation ultimately to resolve some of these problems going forward. Next slide, please. You can review our published fee schedules on the web. This is the site, and it is the Division of Insurance site. It has the fee schedules and the methodology, detailed methodology of how we arrived at them. Next slide, please. This is just a snapshot of one of the fee schedules that you'll see on the site. Next slide, please. And that's it from Colorado.
Thank you. To our audience, if you have any questions, please use the Q&A tab on the right-hand side of the screen. And I recognize there's a little bit of a delay. So I'm going to ask one question, if I can, to our Colorado colleagues. If you could recommend one thing that you've learned to policymakers that you've learned about data, what would that one thing for policy people be? And I'll let you each answer, so you get two answers to the same question.
I think recognizing that the claims in an APCD is not always sufficient to provide fee schedules necessary to support out-of-network legislation, and that details like claim volume, data quality, and even the implementation of the legislation using claims must be considered. So engaging organizations that are responsible for APCDs in discussions about how the out-of-network bill can be implemented before it's actually voted and signed into law would be my recommendation.
Thank you. Does Julia have a different answer or an additional answer that she would like to give?
I'll just add on to that. I think, well, I'll take my mask off. I think APCDs are incredible resources for states to have and use, and it should be used, especially considering the resources that are put into it. But kind of piggybacking off of what Vineeta said, it takes a lot of work and effort to work through some of these data quality issues and work through like the whole management of the project from start to finish. So I think, going forward, I think we'll be looking forward to that when we work with legislators in the future to make sure that, we're engaged very early on in the process and we can educate them about what claims data can and cannot do. That's that.
Thank you very much. Thank you. I do not see any questions in the Q&A for the two of you. If one pop, well, there we go. Can you talk about the impetus for the legislation and what was the discussion like in the legislature?
That is a wonderful question, I think, and I failed to mention this earlier, but if anybody has heard about balanced billing practices, or there's been some controversy over, especially patients being held responsible to pay the entirety of a bill that wasn't negotiated. So there's been criticism of providers just charging exorbitant amounts of money for, an out-of-network procedure. For example, an anesthesiologist providing anesthesia services during an in-network procedure. You went to an in-network facility and you have an in-network surgeon, but then your anesthesiologist is out of network, and then you had no chance to even have the conversation about what that's going to look like. So there's been a lot of criticism of that, and there's been a couple states, actually more than a couple states across the country, who have implemented legislation similar to this. We were involved, I think, towards the end of the process of these, the discussions with, between different sides. I mean, we could talk a long time about that process, but I think there were just a lot of, understandably so, there were quite a few provider groups who were pretty upset with maybe their reimbursement rates going down. And I think, especially with the anesthesiology topic, that was a pretty complicated process to get through, to make sure that we're, making, well, and it's not even us, it was the legislators who are making most of these decisions, and the regulators too. But so just a lot of discussion. It was a lot of back and forth, but I think it turned out to be a good product, and I'm looking forward to any sort of improvements that we can make in the future to this if it ends up happening.
Okay, well, thank you, Julie and Vanita. We're going to move on. Our next presentation will be by Melissa Jordan from the Florida Department of Health. Melissa?
Hi, thank you. Can you hear me?
Yes, sounds great.
All right. Okay, great. Just making sure. Hi, everyone. My name is Melissa Jordan with the Florida Department of Health, and today I'm excited to share some information on one of our newer initiatives supporting overdose-related policy. And as someone who's been with the Department of Health in Florida since 2003, I'm really excited to talk about how we're building off of an infrastructure for surveillance that we've worked really hard to develop over the past several decades. Next slide, please. So a lot of the work that I'm going to be talking about today is supported by a new grant from the Centers for Disease Control and Prevention, the Overdose Data to Action, or OD2A grant, which kicked off in the fall of 2019. And it's an opportunity for state and local health departments to focus on both surveillance and prevention strategies to address opioid misuse and overdoses. Next slide. Under OD2A, CDC provided funding to 47 states, 15 city and county health departments, and 3 districts or territories. That's why we thought this is a really timely presentation to share our experiences implementing the first 9 months of OD2A, since so many jurisdictions are doing similar work. In Florida, the state health department, along with 3 of our largest county health departments, received grants from CDC for OD2A. And then through the state health department grant, we're funding an additional 14 county health departments to implement strategies that integrate efforts with the state level. Next slide. The overarching goals of the OD2A grant, some of the longer term goals, focus on decreasing opioid misuse, increasing the availability of evidence-based treatment, decreasing emergency department visits, and decreasing drug overdose deaths. Next slide. There are 3 surveillance strategies as part of this grant focused on improving morbidity and mortality data, along with some innovative surveillance approaches. All of these seek to support the overarching surveillance goal of disseminating timely and actionable data by supporting prevention activities through dissemination with stakeholders, and by routinely sharing data with CDC. Funding is also being used to build staffing capacity at the state and local level. Next slide. In 2017, the Association of State and Territorial Health Officials, or ASTO, in partnership with the National Association of State Alcohol and Drug Abuse Directors, released a public health framework for addressing opioid misuse and overdoses. This framework is built around 4 key strategies and related objectives. The objectives that are displayed on this slide are examples from the monitoring and surveillance strategy of the framework. I wanted to acknowledge the use of this resource in prioritizing our efforts in our state and organizing our infrastructure needed to implement the OD2A grant. Each strategy area provides policy, program, and partnership level recommendations. So it's a really easy framework to translate into practice. Next slide. This is a slide that I'm very proud of. I'm proud of what it represents and the efforts of our department experts coming together in a cross-cutting approach to develop a state opioid and neonatal abstinence syndrome surveillance plan. And the data sources listed here make up our core health surveillance systems that we use to monitor opioid trends, identify emerging public health issues, and inform decision making. As you can see, we use a variety of data sources, including hospital and emergency department data, vital statistics records, emergency medical service response calls, call data from the poison control centers, as well as prescription drug monitoring program data. Next slide. A critical component of program interest and sustainability has to do with the extent to which program activities are integrated into policy planning documents. So one example I want to share to that end is the inclusion of opioid and neonatal abstinence syndrome goals in our state health improvement plan. Similarly, at the local level, many counties have included related measures in their county health improvement plan. This indicates a commitment to working with stakeholders on program implementation and policy change to address these goals. Another important component of this work is disseminating data. Florida's first approach in compiling key indicators from the various opioid surveillance systems mentioned previously was the development of an opioid profile report available on our county data dissemination website, FL Health Charts, floridahealthcharts.com. Data are typically available at an annual level for most of the data sources I previously mentioned. However, for the opioid response, we've shifted our efforts to trying to provide data quarterly as soon as data are available. We provide state level profiles as well as county specific dashboards for each of the 67 counties in Florida. And we went back to the year 2015 forward, although for 2020, we only have a few indicators that are populated at this point. But as data become available, we make them available as soon as possible. Next slide. So finally, I wanted to highlight two of our surveillance systems and discuss their use in influencing local policies and decision making. Essence is Florida's syndromic surveillance system. The Department of Health collects chief complaint data at least once daily, which covers nearly 99% of emergency department visits throughout the state. Text-based queries are developed and tested and used to monitor condition-specific data. This system allows for epidemiologists to quickly identify outbreaks or unusual trends, including clusters of non-fatal overdoses. Next slide. So this is an example of our data in action. This is an all drug overdose related ED visits query showing the years 2017 through 2020. Now, as you can see, we're carefully monitoring that increase and using that to send data to our local epidemiologists to identify where we're seeing unusual clusters, spikes. This is real-time data, as I mentioned, or near real-time, with daily reporting. And the data presented here are aggregated by week, but daily reports are also available. We have standardized text-based queries that we've developed in collaboration with CDC and the other jurisdictions working on the OD2A grant for all drug overdoses and also opioid, heroin, and stimulant overdoses separately. We report data to CDC every 2 weeks from this system, and all county health departments in the state have at least one epidemiologist who's assigned to be a user of this system. They're able to also receive email alerts for unusual data trends that are picked up in the system. And so there's an automatic alerting system set up to notify the local epidemiologist, who can then share that with data partners, with first responders, with schools, with other stakeholders locally to try to drive decision-making and quick action. Next slide, please.
About 90 seconds.
Okay, great. Great. So another example I wanted to quickly highlight is our work around neonatal abstinence syndrome. Florida was the third state in 2014 to make NAS a reportable condition. So to populate our reportable disease counts for NAS, we use birth certificate data linked to hospital discharge records, and then we search based on the query that you see on this page for reported NAS cases. Next slide, please. This is an example of the data that we're now able to share routinely, and we've started doing this at a provisional level quarterly by linking those two data sets I previously mentioned. This data is being used locally to drive programs that are focused on maternal outreach and hospital collaboration for women who have opioid use disorders to try to get them into earlier treatment, but also to help counsel them through the process of delivery and discharge following a pregnancy and delivery where they might test positive for an opioid. Next slide, please. And finally, I just wanted to summarize with all of that. I know I only shared 2 examples, but some of the limitations and opportunities. I think as we're all used to seeing, there are reporting timelines and the use of administrative data for some of the health outcome monitoring work can be limiting. Data are reported not always in a timely manner, and they may have a different purpose, for example, billing, that isn't necessarily the ideal for health outcome surveillance. Resources can be limited in an informatics and technical staffing capacity, and linkage projects can be challenging endeavors. But for opportunities, I wanted to leave you with some things I really think are going to come from the work all of our jurisdictions are doing with OD2A, and that's standardizing the tracking of opioid misuse and overdoses at a national, state, and local level, building a better integration of state and local infrastructure. In our case, the state, and I think this is common, is taking the lead on most of the surveillance infrastructure development, but the local programs are often the ones doing a lot of the policy work. And so we're able to feed data to them in a way that's meaningful. And related to that, one thing that we're hearing as we're talking to our local stakeholders about how to best share this data is going to lead to the development of communication templates that allow health departments and other staff who may be less comfortable and less familiar with the opioid epidemic to share data quickly. So for example, developing action or communication templates that they can plug in syndromic surveillance data into and share with various audiences, EMS, first responders, schools, other stakeholders locally. Next slide, please. And that's the short and sweet version of that work, and I'm happy to take questions.
Great, thank you. We have a couple of questions for you and have time for hopefully 2 of these at least. One of them is if you could just briefly talk about how ambulances play into this. And the other one is, what did Florida do with the legislature or legislative action to make NAS a reportable condition, and whom do they report to?
Thank you. Yes, so in terms of EMS has been a critical partner for us because, for several reasons. I mean, there are a lot of people who are overdosing more than once and who are choosing to not be transported to a hospital. So if we just rely on hospital and emergency discharge data, we're missing a lot of those cases. And so the EMS calls just to look at overdose prevalence is helpful. Narcan administration, EMS is a great way of tracking Narcan being administered by the EMS. And then we're using it in a creative way in Florida under an innovative prevention strategy. We have 2 county health departments that are piloting the use of their EMS teams to follow up with patients who've recently overdosed daily to make sure they're still on their medication assisted therapies while they're waiting to be enrolled in a treatment facility. So for example, making sure that they're still on their buprenorphine every day, daily for up to 7 days until they're able to get into treatment. And so that's been a really good public health prevention strategy shift that I think will be really promising. On the legislative side, we have a rule, an administrative rule in the state that allows us to add and I guess delete, but mostly add reportable diseases and conditions that we feel are of importance. And there was support from the legislature, some of the leadership in the legislature in 2013 and 2014 around making this a reportable condition. And so we were able to go through the process of filing for rulemaking, hearing public comments, discussing that effort. However, I will say that the trade-off with our approach is that hospitals are required to report already to the Agency for Healthcare Administration in Florida. And so we're relying on passive surveillance for our reportable NAS. And so while it is considered reportable, if the hospitals report to AHCA as required through another rule, then they don't have to report separately on neonatal abstinence syndrome cases. So that's kind of the caveat there. We're not doing active case reporting. Thank you.
Okay, that's the time we have for questions. I do just want to give a shout out. We have a shout out for you from Nicole Helvey. Great to see you here. And it's also good to know that Nicole is here. So thank you, Florida, for helping represent us.
Great.
We're going to go ahead and move on now. Our final presentation will be by Aaron Sandstead and Carl Fernstrom from the Minnesota Department of Health.
Thanks, Norm. Today I'll be speaking about efforts in Minnesota at the Department of Health and elsewhere to draw policy insight from prescription drug data. And the agenda for our presentation will highlight the Minnesota All Payers Claims Database, creation of public use files from the Minnesota All Payers Claims Database, a closer look into the recently released prescription drug files, and we will close with some use cases, an overview of a student competition using the prescription drug puffs, and some new prescription drug policies in Minnesota. Next slide, please. First, I wanted to thank everyone who contributed to this work. Mathematica helped us to conceptualize and implement the prescription drug public use files. The Medical Industry Leadership Institute at the University of Minnesota were valuable stakeholders early on and helped us to draw insight from our efforts. And finally, my colleagues in the Health Economics program at the Minnesota Department of Health, where my team is located, were also critical to this work. Next slide, please. So today we're going to discuss a high-level overview of our newest public use files created from the Minnesota APCD. The Minnesota APCD is a state repository of de-identified healthcare claims data derived from billing records sent by medical providers to insurance companies, plan administrators, and public payers. In Minnesota, the APCD is housed in the Health Economics program at the Minnesota Department of Health. The guiding principles for this project were first, to create public use files relevant to active health policy conversations that were ongoing in the state, provide the data freely and in an accessible and user-friendly format, and stay within relevant statutory requirements to protect patient, provider, and payers from being identified in the data. Next slide. After deciding that our initial focus would be on pharmacy data, partially and due to an active policy debate playing out in the state, and partly due to gaps identified through stakeholder engagement, we brought together a broad group to help inform and guide the creation of our public use files and steer their design. We presented an initial design to the stakeholder group and asked broad open-ended questions about public use file use and what types of analyses might be possible. We then summarized the group's feedback and used it to inform the final public use file structure and design. Next slide. This work culminated in 2 new prescription drug public use files, for which my colleague Aaron Sandstead will now highlight their structure, key design elements, and describe some interesting use cases. Next slide.
Thank you, Carl. We released 2 prescription drug puffs containing summary data from retail pharmacy claims in the Minnesota APCD. One puff is aggregated by non-proprietary drug name. The other puff is aggregated by the first 2 segments of the National Drug Code, which is the drug product code. Both puffs are stratified by payer type. Together, these puffs contain data on over 1,700 different non-proprietary drug names and 11,000 drug products, representing 95% of all Minnesota APCD pharmacy claim spending for 2012 and 2016. To support accurate use and interpretation of the data, we included a user guide with the puff release to walk users through the file structures appropriate aggregations, and example use cases. Next slide, please. The PUFs each contain over 40 variables, ranging from counts and costs to distributions of member demographics. Each year of data in the PUFs includes over 55 million prescriptions, summing to over $4.6 billion. Cost measures are reported for both members and insurers. Demographic distributions include member age group, gender, and geographic classification. PUF records were linked to descriptive drug characteristics from the FDA National Drug Code Directory using the National Drug Code reported on pharmacy claims. Drug characteristics in the PUFs include a generic drug indicator, manufacturer, and launch year, among other variables. Next slide, please. Next, we'll look at 2 example use cases that were derived from the PUFs by simply sorting and filtering records within the spreadsheets. These use cases are examples of questions that can be easily answered by any PUF user. Next slide. In the first use case, we ask, what is the 5-year change in cost per Humira prescription, and how does this differ by payer type? Humira treats inflammatory conditions such as rheumatoid arthritis. As seen in the navy bars in this graph, the price per prescription exceeded $2,500 across all payers in 2012. The percentages in red indicate that 5-year growth ranged from 66% for commercial prescriptions to 93% for Minnesota Healthcare Program prescriptions. Lastly, looking at the green bars, the cost per prescription hovered around $5,000 for all payers in 2016. Next slide, please. In the next use case, we ask, what are the demographics of commercially insured individuals prescribed epinephrine in 2016? Epinephrine treats asthma attacks and allergic reactions. And looking at the first row of data, we see that children and adolescents under the age of 19 years accounted for almost half of all commercial epinephrine prescriptions in 2016, despite representing roughly 1/4 of Minnesota's population. Next slide. Beyond these simple use cases, the PUF data can be the foundation for more in-depth analyses. To promote the creative use of the new Minnesota APCD prescription drug PUFs, we partnered with the University of Minnesota to hold an interdisciplinary health data competition. Carl will give an overview of the competition and highlight select results. Next slide, please.
Thank you, Erin. Now I'm going to highlight how these public use files have been put to use in our state. And as Erin mentioned, the interdisciplinary student competition grew organically out of an active collaboration with our stakeholders at the University of Minnesota Medical Industry Leadership Institute. The competition goals were to have student teams conduct an exploratory analysis using the newly created prescription drug public use files and create policy insights for the state. Results were judged by a panel of experts on policy relevance, analysis, and innovation. Next slide. We had 66 student participants enter the competition, which were split across 10 different departments at the university. Sample topics chosen by the competitors can be seen here and include topics ranging from the projected impact of COVID-19 on cardiovascular prescription utilization and coverage to the total cost of diabetes treatment in the state. The top 5 teams participated in a final presentation on their topic, which was judged by our panel of industry experts. Industries represented included health insurance, analytics organizations, state government, academia, and consulting firms. Next slide. The winning entry found that significant savings were possible if select extended release drugs were substituted with cheaper immediate release formulations. And what can be seen in the figure here is the potential insurer savings across different extended release to immediate release adoption scenarios and payer type. The first bar represents just 25% of drugs from switching from extended release to immediate release while maintaining the same proportion of branded to generic in the sample. And the second bar represents switching 75% of drugs, while the third and fourth bars compare the same proportion of switching respectively, while also adding in a switch to generic immediate release versus branded for additional cost savings. This analysis was carried out for a set of 18 different drugs where therapeutically equivalent immediate release formulations exist, and there's a small difference in pill burden for the patient.
About
Generally-
90 seconds, Carl.
Thank you. No more than one fewer pill per day if you switch from extended release to immediate release. Now, this trend was consistent across all payer types and multiple years. The team's policy recommendation for the state of Minnesota was to conduct a pilot program that allows pharmacists to replace extended release formulations with cheaper immediate release formulations with patients' permission. Health researchers could then formally evaluate the pilot using data from the Minnesota APCD to examine charges in patient and insurer spending as well as medication adherence. Next slide. In closing, I'm going to highlight some recent pharmaceutical policy in Minnesota and expected benefits of using the state's APCD to help evaluate them. Next slide. So 2 examples of recently passed legislation in Minnesota are the Minnesota Prescription Drug Transparency Act, which beginning in 2021 will require manufacturers to report and justify significant price increases to the Department of Health. Secondly, the Alex Smith Insulin Affordability Act creates emergency insulin access and program for longer-term supply for low-income Minnesotans and uninsured and underinsured. Both pieces of legislation grew out of active policy debates in the state and support from the Minnesota APCD and analyses within the health economics program. It's our hope that the legislature, researchers, and the public can continue to use the Minnesota APCD to inform future health policy in the state. Next slide. We believe that analyses such as the ones that have been highlighted here today will continue to both expand the use of the APCD in our state in an effort to inform policy conversations, but also meaningful change in state healthcare policy. Policymakers need robust analyses and high quality data to support a data-driven approach to their efforts. Next slide. Thank you for taking the time to attend our talk today. Here's some additional resources you can find online if you want to learn more or take a look at the files that we have created. We now have time for a few questions.
Yes, thank you. We do have a few questions for you, and I don't think we're going through all of these, but we can save some of them for the discussion sections. The first one is, have you run into any problems with non-uniformative NDC codes such as 10 or 11-digit formats?
We ran into quite a bit of problems with some non-uniform NDC codes. I'll let Erin describe that a little bit because she probably has a better technical understanding.
Yes, so in the Minnesota APCD, the format that we are receiving the NDCs is actually processed by the data vendor. So we have 11-digit NDC and are able to link that without issue to the FDA National Drug Code Directory.
Okay, the next question is, what about clinical impacts of switching immediate to extended release drugs? How did you analyze that? And there's also a follow-up question about that one. Immediately release people forget to take extra doses. Maybe medical outcomes are not so good for them. So what can you say about that?
Yeah, both of those were highlighted by the students who did the analyses, and I'm really just showing you a snapshot there. With regard to the question about people forgetting to take their medications is a good point. And the policy recommendation was actually the pilot project of allowing this switching with patient consent and then following them for adherence to see if it did have an actual impact on adherence or not. Also, in the sample of drugs that were selected for the study, it's 18 therapeutically equivalent drugs. So some extended release formats or formulations aren't therapeutically equivalent, but these drugs that we analyzed or the students analyzed in this example were. And they also only picked drugs that had a minimum threshold for impact to pill burden. So patients would be taking no more than 1 extra pill a day, I think, in the switch from extended release to immediate release, in a way to address that adherence issue. And people are forgetting their prescriptions or the inconvenience. But they did acknowledge there would be a trade-off between that and, the cost burden.
Great. Our last question for this segment, and then we're going to go into an open discussion, is did you receive any pushback from manufacturers about creating a prescription drug PUF? And if so, how did you address or ignore their concerns?
We lucked out. We didn't really get much pushback from manufacturers. It happened in a lot of other states before us, so I think maybe they kind of bore the brunt of it there. We haven't actually implemented our manufacturer price reporting yet, which I think is going to get a little bit more pushback. But in our state policy landscape, really that second piece of legislation I highlighted, the Alex Smith Insulin Affordability Act, is what's really kind of rankled some feathers. And I think they're currently in district court suing the state over that legislation. So for the puffs alone, they really haven't said too much.
Great. Thank you very much. And we're going to go ahead now, and we've got a few questions now for the group, just a few more, but I do want to leave some time for discussion at the end. So we're going to ask those who get these questions to give real brief answers if possible. So this question is we have two questions for Colorado. One question is, can you describe what commercial insurance data you're getting? And the second one is, do you have ambulances in your study?
I can do the ambulance one.
Okay, we're back. So the commercial data we get, I'm the intake analyst, so it's a really good question I can answer. I think we have a total of around 45 different submitters. Some of them are dental only. One of them is our big Medicaid submitter, but we have all of the major commercial submitters. So United, Aetna, Anthem, those are just a few and Kaiser, of course. So we monthly files we receive from these commercial submitters, and we have, I think the total in the APCD is 4.3 million covered lives, and I think about 1 million of those is Medicaid. Don't quote me on that, but that should be on our website. And then Benita, do you want to cover the ambulance?
So on the topic of ambulance services, the legislation did include ground ambulance services, out-of-network ground ambulance services. And we discovered in researching the data in the APCD that a very small percentage of ambulance services were in-network. And so we had very low volumes in the APCD. And further, there was a heterogeneity of the providers of ambulance services, both public and private. And so as a consequence, the Division of Insurance established its own methodology for an out-of-network fee schedule for ambulance services. And they used basically a percent of Medicare formula and did not include public providers in the fee schedule. They only apply to non-public ambulance providers.
Great, thank you. We have another question for Florida, for Melissa. Nathan says, I really like the infographic of your robust surveillance system showing all the data inputs. Have you made a similar graphic showing all of the outputs? That is, how all that data is then processed and then turned to actions or policies in a coordinated way?
Yeah, thanks for that question. We are working with a group at one of our universities to evaluate the effort statewide. And so we are working through that process of crosswalking the inputs, the outputs, and we don't have anything in a pretty graphic yet. But I do think that as we're completing our year one evaluation, that's the direction we're going.
Okay, and that's great. That's going to lead me to my first discussion question. I think we're going to have time for two of these. What I'm going to do is I'm going to ask the question and give you all 30 seconds to respond to each of these questions. We'll see how far we get one. So the first question is this. How would your analysis be different if you lived in a state where there was no APCD? All three of you live in APCD states. How would your research or your policies change if you did not have an APCD? Let's go to Minnesota first, Carl or Aaron.
Good question. We wouldn't have been able to do the analysis at all. And I think the policies that I highlighted towards the end of my talk would be less informed by, what's actually playing out in the data and in our population. So they might be less impactful.
Great, thank you. Let's go to Colorado next and then to Florida. Whoever's in front of the microphone there, that's Benita, all right.
Hi, back again. So it would be very difficult to implement or follow through on the legislation for the out-of-network bill. But I think one fallback would be to establish an out-of-network fee schedule using Medicare fees as a benchmark. So that, I think, could be an alternative to using data from the APCD.
Great, great. Thank Melissa. What about Florida?
Yeah, and in Florida, I would echo, similarly when we didn't have an APCD, and really with this being somewhat new, that's one of the last pieces that I think we'll be rolling into this. We're focusing on some of the, public health timely data reporting systems like syndromic surveillance. So, it is very limited to some extent in what we can focus on, and I think that sometimes our data is very reflective of very specific, maybe vulnerable populations, but not really representative of the whole population. And so that is something that we're hoping to gain from rolling this into our new opioid surveillance program.
Very good. So the second question is one, this is from me. So in terms of bridging data to policy, and we had a question already from Melissa about, informational outputs, what are the top 2 or maybe 3 policy goals that you think the type of data that you're using and collecting could influence? What are those big policy areas where data is going to be key? And let's go this order. Let's go Colorado, Florida, and then Minnesota. I can see that they're fighting. Oh, it's Vanita again. All right.
So one policy goal is obviously affordability. This is part of the Division of Insurance and really the statewide strategy around improving affordability of healthcare in the state. So that's one big policy goal. So I'll just leave my answer at that, because I think that was that's really the fundamental reason why the out-of-network bill was passed.
Okay, great. Thank you, Melissa. Did we lose you? Oh, well, we'll go to Carl and then we'll come. Oh, there we go. Melissa, you're back. What are the big policy areas that data can help inform in the state of Florida? Maybe Melissa can't hear us. Let's do this. Let's have Carl go first, and then we'll come back to Melissa. Or Aaron could be too, either one.
I'll take that one. Thanks, Norm. I mean, for me, data can inform, a broad array of policy areas, and it's really kind of hard to pick 3 specifics. I mean, I think it kind of depends on what's going on in your state legislature or nationally. But, I guess the triple aim, better access to more effective healthcare, complete coverage, and better affordability. Those are kind of the big ticket goals for anybody, I think, here.
Okay, Melissa.
So, can you hear me? Sorry, I had to reload.
Yes.
So, I think there are a lot of things I'm hoping to get from this, but a few things at a state level. I'm really hoping that we identify gaps and work to reduce barriers to things like providing more prescribers who have SAMHSA waiver to provide MAT throughout the state, that we do a better job of understanding and influencing quality treatment facilities that don't lead to repeat overdoses and the cycle in and out of the emergency departments. Those are 2 of our big ones, is I think reducing that cost and making sure that we have coverage statewide, even in our 30 rural counties and areas that often, get overlooked.
Fabulous. Thank you. We have a question from Kenneth. This is sort of a quintessential APCD club question. And basically the question is, what are we going to do about non-fee-based reimbursement? And that's something that we talk about a lot when we're on the data side, but we've got the policy folks present here. So something like Kaiser Permanente and others that are moving towards some sort of value-based payments. could you each just take a minute? Maybe we'll go Carl first, and then Melissa, and then Colorado. Just what are we going to do about that? And is it the death of all of us, or are we going to survive and overcome?
I mean, I think there's a solution out there. I wouldn't say that Minnesota has figured it out. I've seen some other states, and maybe they can speak in more depth, do different types of reporting that are not through claim line level reporting. That seems to be getting towards that question. But as the volume there grows, it's going to be more important that we do figure it out. But I don't think I have the answer here today.
Yeah, I would have to echo that, being a little bit more of an expert on the public health side. I do think Nicole Helvey and our partners at the Agency for Healthcare Administration in Florida are really leading this charge. But I don't know that, I don't want to speak for them, but I don't know that we figured all of these things out yet.
I'll jump in here from Colorado. Last year was our first year in collecting alternative payment model data from payers. So this is non-claims based information. And we're actually leading the charge now to collect that data again come September. And we've done a lot of learning. There's been just a lot of learning to do about different models of payments to providers. And I think really that next step that at least myself, I can't say that I'm going to speak for everybody, but I'm looking forward to is finding a way once we understand the alternative payment models and that market penetration across Colorado and potentially across the nation is then looking at and maybe using APCDs or any sort of other source to see if it's actually making a difference and actually truly affecting health outcomes for Coloradans and the rest of and Americans as well.
Great. Well, thank you, everyone. We have just about 90 seconds left to go, so I'm going to give each of you 20 seconds to say something, whatever you want. Let's start with Aaron and Carl first. Aaron, do you want to go first? You've been kind of quiet from us. Go Aaron, Carl, then Melissa, and then Vanita and Julia.
Yeah, thanks for the opportunity to be here. I hope the APCD data can be continued to be used in whatever format, whether it's public use files or broader.
Okay, Carl?
Yeah, thank you for taking the time to listen to us today. And I just wanted to thank my collaborators who were super important in carrying out this project.
Fantastic. Melissa?
So thank you everyone for participating and thanks for giving me a second with my soapbox, which, I always tell my team that we need to focus on finer temporal resolution, but also geographic resolution. And so, to that end, I think one of the things that I always push on these forums and in these types of conversations is, as we're thinking about what data to collect, it's critically important for those underserved areas that we focus on full address, things like that allow us to drill down in the data and look at those smaller rural communities, zip code level data, census tract level data that really drives a lot of the local decision making. Thank you.
Thank you. Julia?
Ditto to everything that everybody has already said. And also that photo that was taken at the very end of the presentation was actually taken by Vanita's husband, which is, we love that photo. We love Colorado. It's a beautiful place. You can't really see the mountains right now because of the fires, but we're just thrilled to be a part of this NADO conference. And it's firing us up for more analyses in the future and collaborations and achieving that triple aim.
Great. Well, thank you, everyone. On behalf of both NADO and NASHP, we thank our presenters and our sponsors, FOR and Friedman Healthcare. And we're also thankful for everyone that took time out of their day to spend some time with us and learn about data and policy. See you soon. Goodbye.